Hello, esteemed master and practical class members. Today's video is a little different from our usual format. This is a Research Corner episode, where I want to share with you a paper I recently published in the Journal of International Medical Research. The title is Initial Site of Calcifications in Rotator Cuff Tendons, a Sonographic Observational Study. I want to walk you through not just the findings of this paper, but also the clinical question that drove me to do the study in the first place, and what I believe the findings mean for how we should think about calcific tendinopathy in our daily practice. Let me begin with a clinical observation that I have been making for the past 20 years, which eventually became the seed of this research. In my pain clinic, I see a large number of patients with shoulder calcifications. Some of them come in with mild, chronic pain. Some come in with sudden, excruciating pain that keeps them awake at night. And some have no pain at all. The calcification is an incidental finding on ultrasound. Over these 2 decades, I have also encountered countless small, seemingly meaningless calcifications at the tenoperiosteal junction of the supraspinatus, the infraspinatus, and the subscapularis tendons. For 20 years, I could not explain these findings using the standard teaching. Many doctors believe that calcification arises from degenerated tendon, from the so-called critical zone, or from traumatically injured tendon. Many also confuse the histological microcalcifications seen in degenerative tendinosis with the well-defined nodular calcifications of the rotator cuff. These are not the same entity. I have seen many cases in which no other ultrasound diagnosis could explain the pain, and in those cases the calcification was blamed by default, held responsible for shoulder pain that was, in truth, unidentified and unexplained. For a long time, I also believed that barbotage aspiration of the calcium solved the problem, only to discover, again and again, that I was wrong. The journey of a calcification within the tendon is an endless drama, and the more I observed it, the less the standard model could account for what I was seeing. For many years, I followed the standard teaching. According to the classical model proposed by Uthoff in 1976, calcific tendinopathy progresses through 4 stages. The tendon undergoes fibrocartilaginous metaplasia. Calcium is deposited. It rests for a variable period. Then, in the so-called resorptive phase, the body is said to absorb the calcium through macrophage activity. And finally, the tendon heals itself. This framework has dominated the literature for 50 years. And when I was younger, I accepted it without question, because that is what the textbooks said. But over the years, something started to bother me. What I was seeing in my clinic did not match what the textbooks were describing. The critical question was not whether calcifications exist, or even how we treat them. The critical question was much more fundamental. Where does the calcification actually begin? If you look at the literature carefully, you will notice something interesting. Almost every paper that describes the location of rotator cuff calcifications says the same thing. They are most commonly found approximately 1.5 to 2 centimeters proximal to the humeral insertion. This statement is repeated in textbook after textbook. And at first glance, it seems like an answer to the question. But it is not. This is not where the calcification starts. This is where it is most often found in symptomatic calcification. These are 2 very different questions. And confusing them is one of the most common errors in the field. Think of it this way. If you arrive at the scene of a forest fire several hours after it began, and you point to the hottest part of the flames, you might conclude that this is where the fire started. But the real origin of the fire is elsewhere. By the time you arrived, the fire had already spread, and the original point of ignition may already be cold and unrecognizable. The same logic applies to calcifications. The position where we most often detect them is not necessarily the position where they first formed. If we only study fully developed lesions, we cannot answer the question of origin. We need to catch the calcification at the moment of its birth. This was the clinical problem I wanted to solve. So 3 years ago, I designed a study with a very specific and strict protocol. Between March 2022 and March 2025, 3,954 consecutive patients underwent shoulder ultrasound at my clinic. But for this study, I did not include all of them. I applied 3 strict inclusion criteria. First, the patient had to have at least 2 ultrasound examinations at my clinic. Second, the more recent ultrasound had to show a new calcification somewhere in the rotator cuff tendon. And third, and this is the most important one, the earlier ultrasound had to confirm that no calcification was present at baseline. The logic here is simple but essential. If I only studied patients who already had calcifications, I would only be seeing mature lesions. I would have no way to know where they originated. But if I could identify patients whose tendons were clean on a previous scan, and who later developed a new calcification on a follow-up scan, then I could capture the calcification at its earliest detectable moment, at its point of origin. 21 patients met all 3 criteria. The mean age was 59 years. Most of them were women. The mean interval between the baseline scan and the follow-up scan was about 4.5 years. For each patient, I personally measured 3 things using high-frequency linear ultrasound: the distance from the humeral insertion to the nearest edge of the calcification, the long axis of the deposit, and the short axis. All measurements were performed by me, to eliminate inter-observer variability. And the results were strikingly consistent. In 19 out of 21 patients, which is 90% of the cohort, the new calcification was in direct contact with the humeral cortex, 0 mm from the bone. In the remaining 2 patients, the deposit was located just 1 mm away. In other words, every single calcification in this cohort, without a single exception, originated at or within 1 mm of the tenoperiosteal junction. Not at 1.5 centimeters away. Not even halfway there. Right at the bone-tendon interface. This is a very different picture from what the textbooks describe. The second finding was about shape. The mean long axis diameter was about 9 mm. The mean short axis diameter was about 3 mm. The ratio of long to short axis averaged 2.4, and in some cases reached 10. This tells us something important. Calcifications do not grow as spherical masses, as is often illustrated in textbook diagrams. They grow as elongated structures, extending along the axis of the tendon fibers. They are not points. They are lines. And there is a third observation that I think is even more important than the first 2. At the baseline ultrasound, before any calcification existed, most of these tendons were structurally normal. No hypoechogenicity. No thickening. No partial tears. They were intact. This means that de novo calcifications formed in tendons that were structurally intact. There was no preceding degeneration visible on ultrasound. This single observation challenges the oldest assumption in the field. The classical teaching says that tendon degeneration comes first, and calcification follows. Fibrocartilaginous metaplasia is called the precalcific stage. Degeneration is supposed to be the necessary soil in which calcification takes root. But my data shows the opposite. Calcium can appear in tendons that have no visible degeneration at all. And when it appears in one very specific location, the tenoperiosteal junction. So the question becomes, why this location? Why does a calcification always begin at the bone-tendon interface, and never in the middle of the tendon? Let me share with you how I think about this. First, the tenoperiosteal junction is a mechanical stress concentration zone. Every time the arm moves, the tensile force between the tendon and the bone is concentrated at this very interface. The rest of the tendon transmits force, but this junction absorbs it. Second, it is a vascular transition zone. Blood supply is limited here compared to the tendon mid-substance. Third, and this is the part I consider the most important, it is functionally an immune-privileged site. Immune cells do not efficiently patrol this region. In medicine, we know of other immune-privileged sites. The anterior chamber of the eye, the testis, the dorsal root ganglion, These are anatomical locations where immune surveillance is limited by structure and perfusion. Now here is the logic. Every cell in the human body accumulates mutations over time. Some cells drift into abnormal phenotypes. Normally, our immune system identifies and eliminates these aberrant cells continuously, throughout our lives. But in immune-privileged regions, this elimination is inefficient. So at the tenoperiosteal junction, a transformed cell, one that has adopted an osteoblast-like phenotype, can survive. It begins expressing osteogenic markers such as RUNX2, alkaline phosphatase, and osteocalcin. It secretes calcium phosphate through matrix vesicles, exactly like an osteoblast does in normal bone formation. But this cell is not in bone. There is no organized type I collagen matrix around it to guide the formation of proper bone tissue. So the calcium phosphate it produces cannot become true bone. It accumulates as amorphous hydroxyapatite. That is what we see on ultrasound. A hyperechoic focus at the tendon-bone interface, elongating along the tendon axis over time. This is not dystrophic calcification following tendon degeneration. This is ectopic ossification, happening in the wrong place, driven by cells that have forgotten what they are supposed to be. So how does this change our clinical thinking? In my 20 years of observing these lesions, I have gradually come to a conclusion that differs from the textbook. Rotator cuff calcification is not a benign deposit disease that resolves itself through spontaneous absorption. It is, in my interpretation, a structural failure process. The calcium begins at the bone-tendon interface. It extends linearly along the tendon axis. It becomes encapsulated, and during that phase the patient is often asymptomatic. Then, under accumulated mechanical stress, the capsule eventually fails. The calcium ruptures, either outward into the subacromial bursa, producing acute severe pain, or inward into the tendon substance, producing delamination and chronic structural damage. What the classical model calls the resorptive phase, with its phagocytes and new vessels, is in my view the inflammatory reaction after rupture. It is not a spontaneous self-healing program. It is damage control. And when we finally see a calcification disappear on follow-up imaging, this is not, I believe, true absorption. This is rupture and dispersion. The calcium has left because the wall has broken, not because the body quietly reabsorbed it. This is a significant reframe of the disease, and I believe it is much closer to what we actually observe in our clinics. This reframe also helps us understand why pain occurs the way it does. The pain does not arise simply from the structural distortion caused by the calcium itself. Pain emerges only when structural disruption is combined with chemical inflammation and neural hypersensitization. A purely mechanical disruption, on its own, does not generate pain. This is an important principle that is often overlooked. Calcium, in this context, is one of the most lethal chemicals in the human body and a powerful immune irritant. As long as it remains safely encapsulated, the patient is asymptomatic. But once the capsule ruptures, the calcium spreads and reaches the surrounding immune cells. This chemical exposure, layered on top of the mechanical damage, is what produces symptomatic calcification. After rupture, what remains is essentially a dead space within the tendon, a defect that resembles a tear, but a particularly dirty and irregular one. Some of the residual calcium debris is dense and unabsorbable, and this debris hinders the normal adhesion and granulation that would otherwise replace the defect. If the resulting defect is small and mechanically contained, pain may not develop. But if the defect is large enough that its walls separate during movement, it constantly irritates the dead tissue and overwhelms the natural damping mechanisms of the body's reparative response. This, in my view, is the true mechanism of persistent pain in post-rupture calcific tendinopathy. So let me close with what this means for practical pain management. Many of us have experienced the frustration of treating calcific tendinopathy patients who do not respond predictably to treatment. Some get better with barbotage. Some get better with shockwave therapy. Some do not improve at all, regardless of what we do. Why is the outcome so variable? I believe the answer lies in a distinction that has not yet been formally described in the literature, but which I have observed consistently over 20 years. We are not treating one disease. We are treating two very different clinical stages, which happen to look similar on imaging. The first group is the patient whose calcification is still active and structurally intact. The calcium is present, encapsulated, and is itself the pain generator. For this group, aspiration or decompression works. Targeting the calcium makes sense. The second group is the patient whose deposit has already ruptured. The center may appear empty. Only residual calcium remains along the walls. The real source of pain here is no longer the calcium itself. It is the damage that rupture left behind in the tendon, the delamination, the intrasubstance tear, the disrupted fiber architecture. For this second group, aggressive attempts to remove the calcium are not helpful. There is nothing meaningful left to remove. The treatment target has to shift toward the tendon damage itself. In fact, if we perform a fenestration procedure on a patient who is already in this post-rupture phase, the consequence is the opposite of what we intend. Instead of relieving the lesion, we further disrupt an already damaged tendon. If we do not distinguish between these two groups, our outcomes will remain unpredictable. This is a distinction I hope to formalize in future studies. The principle I want to leave you with today is this. We do not treat calcification. We treat the pain generator. And to do that well, we must rely on the natural course of the disease and on the body's own defense mechanisms. Our role is to read the phenomenon as it unfolds within the body, and to intervene at the right time and in the right way, not earlier, not later, and not with the wrong tool. Once you identify which of the two situations the patient is actually in, the treatment plan becomes much clearer. This paper is the first step in what I hope will be a larger body of work, aimed at redefining how we understand and treat rotator cuff calcific tendinopathy. There is much more to investigate. The linear propagation pattern, the rupture pathways, the clinical validation of the classification I just described. These are studies I hope to publish in the years ahead. For now, I hope this Research Corner episode gives you a new lens through which to look at the next painful shoulder that walks into your clinic. Thank you for watching. It is my honor to share these findings and reflections with you. I look forward to seeing you in the upcoming videos.